I'm Shelley from Sevamob. We are fundamentally transforming how healthcare and insurance are delivered in the developing world. Our goal is to get to $26 million in annual revenue within 5 years by going after the market, which has more than 200 million people, and we need $250,000 in funding to get to the next stage. Why should you trust us? Because in just 14 months, on a shoestring budget, we have achieved more than 2,000 subscribers from just 3 towns with less than 5% penetration. And we have been named a top 5 telehealth startup in the world. So in this presentation, we'll talk about the company, the product, the pricing, the financial snapshot, and the competitive advantage. So let's start with the company. I myself have managed several multi-million-dollar product lines for IBM, and I have successfully run a cash flow positive startup, Sevamob. My COO, Shyam Tandon, he has run and managed large sales and distribution networks for companies like GlaxoSmithKline in both rural as well as semi-rural and urban areas in North India. And then our Chief Health Officer is Dr. Darina Stankeva. She is based in Atlanta, and she is board certified in internal medicine, and she has been practicing family internal medicine in Southern Regional Hospital in Atlanta. So this is just a snapshot of our service in action. We launched in December 2011, and you can see the press conference from our launch. Our several health services in Kakori, Mohanlalganj, Lucknow City, in and around Lucknow. So in just 14 months, we have received a whole list of awards and recognitions, and here are just 4 of those. So first of all, a US-based consulting company has named us top 5 telehealth startup in the world, and they have specifically used the word disruptive. NASSCOM Foundation, we were the finalists for 2013 Social Innovation Honors for innovative use of mobile technology for social impact. Village Capital, we received $50,000 in funding from them based upon not just the mentors and not just the investors, but based upon peer voting. So our cohorts in that program felt that we were the most ready to receive that funding. Mahindra Spark the Rise has nominated us for financial support, and we have been featured in Times Now in their Amazing Indian series. So the pain point, it's very straightforward. Low-income consumers, especially those in rural or semi-rural areas and even in urban areas, have very limited access to primary care. They only go to the hospitals or clinics when there is some emergency situation. They also have a limited awareness about why they need insurance, why healthcare insurance, why accident insurance, why life insurance. So the result of all this is that first of all there are the sick days, and then second, there's a loss of income because of the sick days, and then third, when a catastrophic event does happen, there is no support mechanism in place for them to get back up. If you look at the market opportunity, just considering 2 states, UP and Bihar, and we are currently operating in UP. The 2 states together have more than 200 million people. 79% of them are in the rural areas, and their literacy rate is very low, and their per capita GDP is very low. So what do we offer? We provide primary healthcare and insurance. And the model itself is very interesting. We have this field teams of doctors and sales reps. These guys go with an Android tablet which has our proprietary software on it. Now this software can operate in remote areas without network connectivity. They'll find the subscriber, capture medical record information in our electronic medical record system. They will provide preventive care at the doorstep. So things like dental, vision, blood pressure, blood sugar, weight, pulse, nutrition management, everything is done at the doorstep for the subscriber. Now let's say you're a child and you have a worm in the stomach and you need a prescription. In that case, from our software, a travel ticket is created with pictures and some description around it. That goes to our back office MBBS specialists, which we pay on a part-time model, on a per-ticket model. Then let's say there's an emergency. So the subscriber can always call our 24/7 call center, and we take the subscriber to our in-network hospitals and clinics. These are third-party hospitals, clinics, and pathologies. These guys pay us a referral fee for every subscriber that you bring to them. Now there is a motive for us to not do too much of these referrals, because our core model is monthly subscriptions. Now in case of emergencies, the subscribers can also call our 24/7 call center, or they can call that call center at any time and then get the same service that way also. So if they have the inpatient health insurance, the coverage in the hospital is at no extra charge to them, up to 30,000 rupees, which is enough to cover things like somebody having a fracture, somebody having a baby. All of that is covered in that 30,000 rupees. So the model works very well from that perspective. And the insurance policies which we bundle are below poverty line insurance policies. So these include accident insurance, and these include the inpatient health coverage which I mentioned to you. Now we are heavily using technology, which is why we can get to the price point which we are going to mention on the next slide. So the technology we use first of all is our own electronic medical record, which is based upon industry standards. Those of you who have some healthcare background, this is based upon HL7 industry format. So it can be converted very easily into anything which can be understood by Medicare, Medicaid, or any government institution anywhere in the world. And similarly, we can import data from that place. Similarly, we have this mobile application which runs on the Android tablet, that runs fully offline. The complete subscriber information is available on that tablet to our field team. So let's say you want to find out when was the payment last done by the subscriber, or when was the last travel ticket created by the subscriber. All of that information is available right there. You might wonder, why is that important? Because we are not just operating in urban areas, we are heavily operating in the rural and semi-rural areas which are adjacent to the urban areas. So the network is either very poor, or there is no network available in those areas. So that offline is a big competitive advantage for us. Now we have a back-end portal where we track every single thing which is happening in the field. So for example, we would do within 48 hours we'll do a survey to find out if the subscriber received the welcome kit, if the initial checkup was done for them, if the medical record was captured in the system or not, if the service was explained to them clearly or not. So we rate our own field teams, and we manage all of that rating information in our system. We also rate every single specialist who is in our system. So the MBBS doctors, we rate them. The back office hospitals and the clinics, we rate them. And the pathologists, we rate them. So we have detailed information on every single entity in our network. So why is this important? First of all, let me talk about the marketing piece of it. Instead of going door to door, where our expense is going to be much higher and the number of subscribers we can do is much lower, we sell in bulk in schools to students, in factories to employees, to labor unions, to construction unions. When we go to these places, in a half-a-day camp, every month, we can cover, for example, a couple of hundred students, or we can cover 50-60 employees. So the cost of operating is reduced a lot using this model. Then when the subscriber is signed up by the field officer, the subscribers are signed up by field officers which are assigned to specific coverage areas. Now we have introduced one more innovation in this process. For example, we have partnered with a Dasra cohort here, an alumni of Dasra, SMB Wheels. Now SMB Wheels has a network of 1,000 rickshaw owners in Varanasi district. They have a captive audience. All we have to do is deploy a field team in that area in a very low cost fashion. Then we can address more than 1,000 rickshaw owners, right? So how does it help? This is our price point. For 100 rupees per subscriber per month, we can offer primary care. And remember that primary care includes the preventive checkups at the doorstep, the prescriptions at the doorstep, emergency care through our in-network hospitals and clinics, where in the base plan, the subscriber pays separately. Okay? It also includes accident insurance. The accident insurance depends upon the duration of the plan the subscriber has with us. If the subscriber is signing up for a 3-month plan, we give them 25,000 rupees accident insurance. If they sign up for a 6-month plan, we give them 50,000 rupees accident insurance. A 1-year plan is 1,20,000 rupees accident insurance. And remember, these are below poverty line rates. So the cost to us and the cost that we pass on to the subscriber is very low. Now in our premium plan, along with primary care and accident insurance, we bundle the healthcare insurance also. That premium plan is only $3 per subscriber per month. So even that is not much. The revenue stream is threefold. One, it's monthly subscriptions. Two is the referral fee that we get from the third-party service providers in our network. That includes the hospitals, the clinics, the pathologies, and so on. And then the golden nugget in all of this is the ad revenue. All of you have used, I'm assuming, Facebook. Now you don't pay anything to Facebook, but Facebook tracks every single thing about you. But Facebook does not share your actual data with anybody. What they share is, for example, if you want to run, let's say on our network, somebody wants to run, like GlaxoSmithKline, a campaign to target the diabetics. So we can tell them exactly where in Lucknow district, for example, they should go and introduce the new drug, for example, right? So that is the biggest nugget in this entire model. Now, we have added a new service on March 1st. When we were selling, we noticed that people in the orphanages and old age homes could not pay for our service, even though the price was pretty low. So what we did was we set up a website where somebody in the US or elsewhere for $4 a month can pay for the primary care of a kid in an orphanage or an elderly person in an old age home. In return, they will get on a daily basis or a minute by minute basis the health updates of the person they are sponsoring. How many of you have given money to some cause or some, just like by a show of hands, how many of you have given money to some cause? Now, how many of you have actually on a daily basis been notified how your money has been used? Nobody. We are the only company in the world which on a telehealth model can do this because of our technology. So what is the competitive advantage? We face two types of competitors. One is companies like eHealthPoint, and we have some cohorts in our batch also who are doing this model. They'll go and set up a clinic in a remote area. They'll build a broadband connection out, and then they'll put some hospitals and tie up with some hospitals in the back office. The problem with this model is the broadband connection is expensive, the real estate of the clinic is expensive, putting an MBBS doctor in the clinic is expensive. So before you know, you pretty much end up with an expensive model. Similarly, there are government-run primary care clinics. Now these clinics, first of all, they have a paucity of doctors, skilled MBBS doctors, and then second, it's very overcrowded. People go there when the problem has already happened, right? The advantage of our model is, first of all, we have a mobile team. We can deploy it in a very flexible fashion. We go where the customer is. We go to a factory, we go to a school, we go where they are. So our model is much more flexible. Second, because of our mobile technology, which is not, does not need a broadband connection, we can operate much lower than anybody else anywhere in the world. So our milestones and roadmap. So first of all, we have raised 2,000 subscribers from just 3 towns. Second thing, and this is a huge thing for us, we actually replicated this model in Liberia, in Africa, in end of February 2013, just within 14 months of our operation. That's a very interesting model that we are using there. That company is a franchisee of ours. They are licensing our technology, our business practices. They are deploying their own field teams. So we get a royalty with no additional investment on our part, and this is the new revenue stream for us, along with the other revenue streams I mentioned to you earlier. We are also, as I mentioned earlier, starting operations in March in Varanasi. End of March, we are starting operations in our third district, Gorakhpur. So we have pretty flexible coverage from that perspective. Our roadmap is to grow from 2,000 subscribers in first year to 1,20,000 subscribers by year 5, and grow from 4 field teams to 240 field teams. In terms of financial snapshot, we want to get to 26 million in annual revenue in terms of dollars by year 5. And we'll break even in the second year. We will break even this year. We have been using our seed capital from Village Capital extremely wisely. We got the check in October, and we have used only 20% of the check. And we have shown all these results even without using that capital. So we are very, very, very capital efficient. In terms of funding, we invested to $30,000 of our own money. We took $50,000 from Village Capital convertible note. We are looking for $250,000 in equity funding. $100,000 from there will go for 16 additional field teams. Another $100,000 will be going for additional back office specialists and the management team, and then $50,000 will go for SG&A. And our exit strategy is IPO. Our board of advisors includes Dr. Barry Patel, who is CEO of a healthcare company TTM Inc. in the US. He has more than 200 healthcare consultants working with him, and he sells to a lot of hospitals and clinics. Dr. Nirav Desai is the CEO of Hands-on Telehealth, and he is very widely known in the healthcare industry. And then Kapil Yadav, he is helping us from the equity and investment perspective. So why should you invest in Sevamob? First of all, we on a shoestring budget in just 14 months have done 2,000 subscribers from just 3 towns with less than 5% in penetration. And we have been named a top 5 telehealth startup in the world. We are looking for $50,000 in annual funding, equity funding, and we have received a whole bunch of awards and recognition. I just want to real quick before ending this, want to show you a video of our coverage in Times Now.
A villager getting medical assistance at his doorstep. A farmer being able to seek advice from an agricultural expert. These are some of the things that Sevamob has brought into the lives of those residing in the villages of Cohort and Mohanlalganj.
Sevamob provides a healthcare and insurance to low-income, low-country by the team of the doctors and the field representative. They carry Android tablet with them and supported by 24/7 call centers, MBBS doctors, pathology center.
Villagers are entitled to a monthly visit by a doctor who not only carries out a routine checkup but also informs them about preventive methods.
कोई क्रॉनिक बीमारी है तो उसको भी बताता है, अगर जरूरत पड़ती है तो उनके पैथोलॉजी टेस्ट भी कराता है. If required, they recommend course to.
हमको तो अच्छा फायदा लग रहा है. दवाई इलाज से कोई तकलीफ होती वो लिख देते हैं और होती तो पास दे देते हैं, नहीं होती तो लिख देते हैं.
Sevamob has also started offering healthcare services to schools in the village of Cohort.
किसानों के बच्चे हैं, ये लोग ज़्यादा जानते तो है नहीं, ज़्यादातर गाँव के लोग हैं, तो इस संबंध में उनको नॉलेज नहीं है कि क्या खाना चाहिए क्या नहीं खाना चाहिए. वहाँ पूरा दिन खाना खाते रहे या पूरा दिन छोड़ दें और खाने न खाएं तो ये आपको दिक्कत हुई सारा छोड़ दिए. तो ये जो है ये लोग अपना ठीक से जो है उनको बताए कब खाना चाहिए, कब खाना चाहिए, क्या खाना चाहिए, क्या नहीं खाना चाहिए और बीमारी से कैसे बचा जा सकता है.
They have touched the lives of farmers who now have the facility to consult field operators about their crop cultivation. Even animal husbandry.
So I just wanted to end this here and open this up for questions.